Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers, producer of Public Health on Call, with a message for our superfans. Do you often listen to Public Health on Call, share episodes with your friends and family, or even use them in your teaching and learning? Would you be willing to speak with us so we can learn more about what you like or what you'd like more of from us? If so, we'd love to hear from you. Email us at publichealthquestion@jhu.edu and let us know that you'd be interested in providing some feedback. We can't wait to hear from you. Thanks for listening. Today, an update on Mpox and a deadly outbreak that's spreading across Africa. Stephanie Desmon talks to Dr. Chris Beyrer, director of the Duke Global Health Institute, about what is becoming an epidemic of international concern. They discuss the origins of Mpox, surveillance, treatment, and vaccines, and what needs to be done now to contain the spread. Just a note that after this conversation was recorded, the WHO has called for a panel of experts to assess if the outbreak constitutes a global health emergency. Let's listen.
Chris Beyrer, thanks so much for joining me again.
Wonderful to be with you, Stephanie.
So today I wanted to talk about an outbreak raging in the Democratic Republic of Congo. It's monkeypox. And this situation feels very different than even a few months ago. And I'm wondering if you could maybe just start at the beginning and remind everybody what monkeypox is.
Right. Well, we've changed the name now of the disease to Mpox. And the reason for that is monkeypox was never a very accurate name for this virus. This is a pox virus. It's in the same family as smallpox and a number of other pox viruses. And it has mostly been a rainforest virus in Central Africa, particularly in the DRC, the Democratic Republic of Congo, and some of its neighboring countries. And typically, it's what we would call an endemic virus. There are occasional spillovers to humans, many of them in children, mostly because of picking up sick animals, particularly rodents. The reason it was called monkeypox for a number of years was because there was an outbreak actually in a German monkey breeding research facility in which rodents had been brought in from Africa, and the monkeys became infected. But it actually is probably a rodent virus, and it's a virus that can hop around on a lot of different species. And in the past, there was not a lot of evidence for much epidemic transmission from human to human. So there have been cases going on for decades. There was an outbreak some years ago in the US. It stayed pretty small, which was basically people importing exotic rodents from Africa, particularly the largest rat species, which is an animal called the giant Gambian pouched rat, which is like a meter-long rat, and people have them as pets. Apparently, they're super smart, fun animals if you're a rat person. But nevertheless, those rats infected prairie dogs in a pet shop, and then humans got infected from them, and there were some household cases. But basically, it's kind of stayed that way until 2017. In 2017, there was an outbreak, clearly very different, in a new country, Nigeria, that had not had cases of Mpox in the past. And it appeared to really be changing in epidemiology. It turns out that there are two clades of Mpox, clade 1 and clade 2. Clade 1 is the one that you see mostly in Central Africa and the rainforest areas in DRC. Clade 2 is less lethal, but it turned out to be significantly more transmissible and to turn up increasingly in human-to-human transmission, where there's no wild animals involved, and primarily not among children, but rather among reproductive age adults, and appearing to be transmitted through close, intimate skin-to-skin contact, including sexual contact. And that epidemic continued in Nigeria for 5 years without really the world paying much attention. epidemiologists were paying attention because we are always concerned when a virus leaves its geography and appears in a new place. And of course, DRC is a very large, very largely rainforest country. Nigeria is the powerhouse of Africa, and it is a country with lots of international flights, lots of connectivity. There are Nigerian expatriate communities. And so if you were a gambling person, you would predict that this virus would have escaped from Nigeria. And that's exactly what happened. Unfortunately, what happened was that it initially spread among gay and bisexual men who have sex with men. That summer, the summer of 2022, was kind of the first time the world was getting back together after COVID. There were two big pride events in Europe, one in Spain and the Canary Islands, the other in Belgium. And the next thing you know, we had a global outbreak of Mpox among primarily men who have sex with men. A number of deaths, but many more cases. And that came under pretty rapid control because unlike many other viruses and many other outbreaks, in the case of Mpox, we have a good vaccine, we have a good antiviral therapy, and we know a lot about the epidemiology. So it was rapidly contained. There still have been cases in a number of countries, particularly Brazil, Nigeria, DRC, but it looked like an outbreak that came under control. Now, for the last several months, something else is happening, which we're more concerned about. And this is now an outbreak that, again, looks more like person-to-person transmission, sexual transmission, but it has really erupted in a conflict and mining zone within the Democratic Republic of Congo, a place called South Kivu province, which is very close to the borders of Rwanda and Burundi, neighboring countries where there's a lot of population movement. And the area has a great deal of mining. DRC is one of the most mineral-rich countries in the world, despite the fact that its people are incredibly impoverished. A lot of that is because of chronic conflict and corruption. A lot of the mining that goes on there is unregulated. And there are enormous mines in South Kivu province, and that appears to be where this outbreak has taken off. Between miners and, very importantly, between women who sell them sex. And there are sex workers from at least 6 different countries in this mining sex work area. And many of the cases have been clearly sexual transmission with Mpox lesions, vaginal, rectal, penile, very much sexual transmission. Now, why are we so concerned? Well, the first thing to say is that this is the more lethal clade of Mpox and has a higher case fatality rate. The current case fatality rate is around 3%. That's nowhere near as high as smallpox, but it's still high. The number of cases is very disturbing. There have been at least 27,000 cases reported, which is a big outbreak, and over 1,400 deaths. So that's very concerning. Now, Mpox generally is a self-limited disease. It starts usually with a fever and headache, and then you get this very characteristic rash. And the rash can be focal, say on the genitals, if you've had a genital exposure, or if you're a child and you've picked up a sick rodent, you might get a more disseminated picture that looks kind of like measles or smallpox. But if you have immunocompromise, if you're somebody who does not have a good immune system, you can get really disseminated disease, and it can be quite rapidly lethal. And that, of course, is a particular problem for people with HIV. So in the US, most of the Mpox deaths were in gay men living with HIV. Of course, in places like the Congo, there's a lot of reason to be immunocompromised: malnutrition, tuberculosis, HIV infection, and others.
Does the lack of a good healthcare system over there, is that contributing to being unable to control it?
Absolutely. So the surveillance system is weak. Remember that this is a conflict area. There are many displaced people. There has been shelling. What this area is known for, if you think back to the early 90s and the Rwandan genocide, was that the people who perpetrated the Rwandan genocide were largely from the Hutu minority, and they were driven out when the genocide was ended by the Tutsi forces led by Paul Kagame. He's still the president. But that conflict with the Hutus in DRC has never really ended. And so there's shelling, there's refugees, there's displaced people. It's a very hard place to do anything in public health, but in particular to try and contain an infectious disease. Second issue, which is really shocking, has been that there's just been such a lack of international response. I mean, when we got word some months ago about this outbreak and started seeing the number of cases, it was just so clear that they desperately needed vaccine. There were no vaccines in the Congo. And the vaccine that we have, the Jynneos vaccine, is not approved in children. So you can't use it in children. They now have 50,000 doses donated to DRC, but they have not yet begun vaccination programs. So it's really a challenging moment.
And I know the WHO fears this could be a new epidemic. Talk to me about what characterizes this that way.
Yes. Well, it is an epidemic. There is no question that this epidemic is underway. It's an infectious disease where the epidemiology appears to be changing. As I said, over 27,000 cases already in this outbreak, over 1,400 deaths. And it has now spread to at least 15 countries, including Rwanda and Burundi, which border DRC, but also other cases in other African countries. So what you're worried about is a regional outbreak and the pandemic potential globally, because we are all about one 10-hour, 15-hour plane flight away from Mpox at this point, right? The world is not the way it used to be. It took a very long time for smallpox to spread and be contained, but this is different. So you raised the question about whether or not WHO and the WHO director, Tedros, are going to declare this a public health emergency of international concern. I think it's past time. I think when you have 15 countries and when you have the potential for spread in this conflict zone and in this zone where there's quite weak healthcare systems, this is a real concern. And by the way, an outbreak of a sexually transmitted infection among heterosexuals in the Democratic Republic of Congo is partly how the HIV epidemic began. This is the same region. So for those of us who think about that, rainforest viruses like HIV do not always stay in rainforests.
So if they do raise the alarm on this outbreak, what does that mean in practical terms?
Well, right now, there's only been about $10 million spent on this outbreak by the Africa CDC, and they have been doing fantastic work. They really have, and they've been very on top of this. They need, I would say, between 10 and 100 times that in terms of resources, right? We need to be manufacturing the vaccine really at scale. There needs to be aggressive vaccination campaigns and programs. We also need to get the antiviral much more available to the sickest people. We really have to, in addition, make sure that we're protecting people with immunocompromise. There has to be much better screening and access movement of populations across these very porous borders. So that's important. And we really need to be doing much better surveillance. There's also a lot of clinical training. Doctors and nurses and community health workers, people need, particularly in countries that have never had Mpox, they've never seen it and they don't know what it looks like. And so we really need a major education campaign. And of course, we need testing to be much more widely available. That was a big problem in the US, was getting confirmatory diagnostic testing. It took a long time, a number of weeks to get that up and running. The Africa CDC is the right lead organization working with WHO and working with the governments of these countries. Some of them work well together. Others are in open conflict with each other. So it's not going to be easy, but it needs to have started several months ago. So we're already behind and we're grossly underfunded.
As people who have just lived through the COVID pandemic, are we afraid it could come to those levels?
Stephanie, it's such an important question, and it's so frustrating because, one of the things you always hope when you're coming out on the other side of a global pandemic, of a new infectious disease, is that we're all going to have learned our lessons. And instead, what it feels like, again, is more of a sense of, oh no, not another outbreak, and not a lot of global urgency about this. We are in a period that people have described as polycrises. There's the Russia-Ukraine conflict, there's Gaza, there's the meltdown of Sudan and the civil war there. There's so many challenges and conflicts in addition to the climate challenge underway in so many places that there's a sense of not really the enthusiasm for responding to this in the way that it needs to be. And of course, one of the lessons we've learned from many years of this work in public health and global health is that you can never get back the early period of an outbreak. If you can contain something when it's under 100 cases or under 1,000 or even under 10,000, you are in such better shape. Now we're past that. We're talking about, 27,000 cases, that the early period is already over. It's just that we're not seeing it because most of the people are in remote rainforest Africa. But nevertheless, this is an outbreak we need to pay attention to. Now, does it have the same epidemic potential as COVID-19? No. It requires intimate person-to-person contact. It is much more like a sexually transmitted infection. COVID-19, of course, as we all learned, is so infectious and with an activity that none of us can stop doing, which is breathing. So masking helped, of course, vaccines helped. But, here we are with very effective vaccines and with very significant herd immunity, and we've still had a summer of COVID. We've had lots and lots of outbreaks and cases. So this is not COVID, but it is a serious infection. It can be scarring. And of course, as we've seen, for about 3% of people, they're going to die of this, particularly children. The fatality rates are higher in children. And the fatality rates are substantially higher in people with immunocompromise.
Could this become an HIV?
Well, HIV has a much longer period of infectiousness. So untreated people can be infectious for many years. So that is what allowed that virus, which has quite low transmissibility, to spread so widely. This is different because it's a much clearer infection if you have it. And once you recover, you're generally immune. Of course, nobody recovers from HIV, or very, very few people. So it's probably not that, but it probably is worth thinking about, for example, some other infections like syphilis and gonorrhea, which are still with us. We had a syphilis outbreak in the US last year. We had over 4,000 congenital syphilis cases, which is a significant increase. And syphilis is easily curable, a single shot of penicillin, but there are always these problems because of the stigma and the shame, because of the need to screen, because it's sexually transmitted, that have really hampered spread. With Mpox, you have a special challenge because, for example, in many of the countries where it's spreading, the majority of cases do appear to be in gay men. That certainly is the case in South Africa. Most of the cases have been in gay men. South Africa, it's legal to be gay. In Burundi, it is not. Right. And so there's real challenges there. Nigeria, of course, has some of the harshest anti-gay laws in the world, and they really hampered the response there. Nigerian epidemiologists were sending me data and saying, well, 85% of our cases are in men, and they're men aged 20 to 40, and they have penile lesions. And I'm thinking to myself, okay, this is an outbreak in gay men. You just can't say it because it's illegal to say it, and it's illegal to ask.
Mm-hmm. Well, Chris Beyrer, thank you so much for joining me.
Thank you, Stephanie. I hope that was helpful.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.